Many challenges exist still in relation to non-motor symptoms. These are firstly lack of understanding and also still relative lack of research in many areas of why some of these symptoms occur. How are they different to non-motor symptoms that we observe in the general population? Some of them are very common, such as anxiety, depression, constipation in general population, as well as in Parkinson's. So there is that aspect of it to dissect out what is really related to Parkinson's as opposed to what we see in a general population. Secondly, we have the problem of overlap. Although we talk about non-motor subtypes, once you go into the advanced stages of Parkinson's, all the dopamine neurotransmitter symptoms might be involved. So there's almost always an inevitable overlap between the subtypes. What does that one do in terms of that particular area? We also don't really know clearly the natural history of these non-motor subtypes of Parkinson's in the long run. So we need to understand that to see whether the therapy affected in the early stage can actually help the long-term outcome. We don't really understand that, so that remains a challenge. Another challenge is the fact that treatment for different non-motor symptoms still is far from optimal. If you look at strong evidence base, in other words, level 1 trials, randomized placebo-controlled trials, to address some key problems which affect the people with Parkinson and their carers. I'll give you some example: dribbling of saliva, excessive daytime sleepiness, urinary dysfunction, bowel dysfunction, apathy, fatigue, even REM behavior disorder, hyposmia. We don't have seriously good evidence-based treatment for these. We use pragmatic clinical experience-led treatment, but clearly there's a need for the industry and the societies to work together to improve management of this condition by providing good quality trial. But there are many challenges in doing such clinical trials, and that's what we need to overcome. And finally, the issues around quality of life assessment in relation to non-motor symptoms also needs greater focus. The other question was how we can improve this. Well, we have now many aids. The scales can help us improve and look at the outcomes in a qualitative and quantitative manner. There are validated questionnaires, the non-motor symptoms questionnaire, for instance, which allows the patient to describe the symptoms to the doctor, to the healthcare professional. And finally, we've recently also described the dashboard. Use of the dashboard ensures that the doctor or the nurse or the healthcare professional are not missing important parameters that must be taken into care when you're seeing a patient. For instance, bone health, vision health, gut health. These are all very important things for the overall wellness of the Parkinson patient. And this dashboard allows you to make sure that you haven't missed doing that.